developing a radiomics-based machine learning framework.
Right, specifically to evaluate immunotherapy efficacy in non-small cell lung cancer patients, the ones who have bone metastases.
Yeah, which is an area that's, well, it's notoriously tricky to measure, right?
It is a significant clinical challenge because current response criteria, like RECIST, they are mostly optimized for soft tissues.
Okay, so they just look at the size of the tumor.
Exactly. Standard medical imaging usually measures tumors just by looking at their diameter, but bone metastases are complex.
Right.
They can break the bone down or, build it up irregularly. So just measuring a lesion's diameter doesn't really give you an objective assessment of how the disease is responding.
I mean, it's kind of like trying to figure out how much water a sponge is holding by only looking at the size of its shadow on the wall.
That is a very accurate way to put it.
Yeah, you might see the shadow get a little bigger or smaller, but you are completely missing all of the internal structural changes of the sponge itself.
Exactly. And that measurement gap is precisely what this study addresses. They needed an objective, non-invasive measurement tool.
So if human eyes and, standard size-based criteria can't see these internal microchanges, how do they actually measure them?
Well, the researchers essentially had to extract data that's already hiding in the images. They analyzed pre and post treatment chest CT scans from 99 patients.
Okay.
And first, they used an automated tool called TotalSegmentator to isolate just the bone structures.
Oh, I see. So they cut out all the background anatomy, the soft tissue, all of that. What are they looking for inside those isolated bones?
Oh, they extracted 1,051 specific radiomic features from those scans.
Wow, over 1,000.
Yeah, 1,051. Because instead of just looking at overall size, radiomics translates the image into quantitative data. It measures things like density, texture, and the microarchitecture inside the bone matrix.
Wait, 1,051 features per scan sounds like a lot of heavy lifting. Why couldn't they just use standard patient data? I mean, things like a patient's BMI or age or treatment duration are already available in the clinical charts.
They actually did test those clinical variables, but the data showed that they didn't meaningfully improve the model's performance.
Really? They didn't help at all.
Not significantly, no.
Yeah.
General factors like age or BMI don't tell you how the physical architecture of a specific bone lesion is reacting to a drug.
Right, that makes sense.
You really need that high-dimensional radiomic data to capture the subtle biological shifts happening inside the bone.
So they extract all the structural data and feed it into machine learning classifiers. I think the paper mentioned random forest and XGBoost. What do the quantitative outcomes actually show?
The random forest model, using only post-treatment features, performed the best. It achieved an AUC of 0.94 and an accuracy of 79.2%.
Let's break down that AUC number for a second, just to be clear for you listening. An AUC of 0.94 essentially means the model has a 94% probability of correctly distinguishing between a patient responding to therapy and one who isn't.
Yes, it is a very strong mathematical signal.
Yeah.
And a crucial finding here is how they evaluated the lesions.
Oh, right.
The data demonstrated that evaluating the overall response across all lesions was mathematically superior to just evaluating the single largest lesion.
Because metastatic cancer isn't uniform, right?
Right.
Different spots in the bone might react differently.
Exactly. So looking at the aggregate picture gives a much more accurate assessment.
But here's the part that really stood out to me. I would assume, logically, you'd want to compare the baseline pre-treatment scan to the post-treatment scan to calculate the difference.
You would think so.
Yeah. But the model performed best using only the post-treatment scans. Why is just looking at the aftermath mathematically better than looking at the difference?
It mostly comes down to variability in noise. The post-treatment scans capture the most distinct structural changes induced by the therapy.
Okay.
When you try to subtract the baseline values from the post-treatment values, you often just introduce mathematical noise. The baseline scans didn't add predictive value.
Interesting. So the treatment-induced changes on their own just provided the clearest pattern for the algorithm.
Precisely.
So if you are listening to this and, you are studying oncology or developing diagnostic tools, this paper offers a highly citable objective framework.
It really does. It demonstrates that post-treatment radiomics effectively capture therapy-induced microstructural changes, although the authors do note an area for continued refinement.
Which is what?
Distinguishing between stable disease and actual disease progression remains challenging.
Because the visual and mathematical categories might still overlap a bit.
Yes, exactly. But it is still a highly rigorous framework.
Well, it is certainly a massive step up from just looking at shadows, and it leaves you with a much broader question to consider. If a standard post-treatment CT scan contains this much hidden structural data about therapeutic efficacy, what other routine clinical images are currently masking complex biological responses that human visual criteria simply cannot detect?